In this audio lecture, we're going to be expanding our conversation about conditions that affect urine elimination. We're going to be talking about nephrolithiasis in this audio lecture. All right, so what is nephrolithiasis? Nephrolithiasis can be described like a drain in your house, okay? And really, this is an obstructive disorder, okay? So it's a urinary tract obstruction and is blocking up fluid from leaving your body, okay? Now, we all know that if we get a blockage in our plumbing system somewhere, this prevents fluid release or prevents the water draining from out of the toilet, from out of the sink, or out of the toilet, right? And so the same thing can essentially happen in our bodies as well, okay? And this causes the system to back up, and this can cause disruptions to normal function, okay? And it can really create a lot of pain in the process as well. Okay. So in nephrolithiasis, we see the presence of renal calculi, right? So those renal calculi are otherwise known as kidney stones. So kidney stones can form in your kidneys under certain circumstances. And so they generally form in the ureters, renal pelvis, somewhere along these lines, or the bladder. Generally, they are produced from the components being in too high of concentration, just as a generality. And so we'll actually talk about some specific types of these kidney stones or nephrolithiasis, and are these renal calculi. So we have the stones actually made up of multiple different types of substances, and so here are the four categories: calcium, struvite, uric acid, and cysteine, and I detail each aspect in this audio lecture. So here are some examples of kidney stones, and so you can see that some are very small, and so this is a centimeter, and so we see that some are very small, whereas others are very large, and they looks like about 2 centimeters for this one right here that is jagged, right, and some others are smooth, and so you might imagine that passing something like this is going to be painful, and we might actually break that up before trying to pass it, whereas these might pass a little more easily because they're smooth and rounded. So their appearance and size are variable, and so they are going to vary based on what they are comprised of. So we see that there are some general causes to these formations of renal caliculi, and that pH changes of the urine can cause this. We see that accumulation of excessive salts, so dehydration can result in excessive salts and leading to crystal formation and circulation, and then in turn in the urine. Okay. Bone disease, so bone disease would be releasing more calcium, and this calcium can form crystals, and we actually see that is one of the categories of these kidney stones. And then gout. Gout is a condition in which uric acid increases to such an extent that it comes out of solution, forming crystals. Okay. We have other conditions like renal disease, and so renal disease is essentially you're decreasing your filtration, and you're decreasing your ability of the kidneys to actually form waste products, and so we can see that somewhere along the line something is not working right. Maybe we're not moving enough calcium back out of the urine, and it's just increasing in concentration. This can lead to crystal formation, right? Or we could get a dietary increases of these salts, maybe some amino acids or uric acid, right? So if we eat a diet high in protein and we are prone to gout, developing these uric acid crystals, we might find that we need to adjust our diet based on the conditions of our body and the presence of these kidney stones. Eventually you figure out what triggers their formation and what type of kidney stones you're more susceptible to, so you can really plan out your diet and more appropriately so that you don't develop these, because they are very painful. Okay. So we know that risk factors can include family history, obesity, hypertension can lead to this, and so this hypertension can lead to renal damage. Yeah. we know that your diet has a tremendous amount to do with this as well. And so see that we have protein, low calcium, also high calcium can cause this calcium crystal formation. And so calcium in multiple levels can cause this. Sodium, sodium crystals can form in that urine. And so calcium, this is going back to table 7-5, and so calcium crystals specifically, or calcium colliculi, are going to be excess dietary calcium, okay? Or increased absorption of calcium from the small intestine. So if you think about this, we're putting more calcium into circulation. Well, that's more calcium that has to be reabsorbed in the kidneys, and we see that the kidneys don't always absorb too much calcium based on hormonal control or based on just abundance of it being in the filtrate. And so we see that hyperparathyroidism, so parathyroid hormone, increases blood calcium. And so if you are producing too much hyperparathyroidism or parathyroid hormone, okay, you're going to be elevating your blood calcium more. And so this elevated blood calcium can result in increased calcium in your filtrate of your kidneys. Okay. So in the kidneys, if we have elevated levels of calcium, it's easier for that calcium to come out of solution, particularly if now we're dehydrated. Okay. And so along the kidneys, we have, so the nephron is the functional unit of the kidney. And so along that structure, along the nephron, we absorb things and we secrete things, right? So most of our reabsorption occurs in the proximal convoluted tubule. We set up our concentration gradient, our osmotic gradient in our renal medulla via the nephron loop. Okay, and the distal convoluted tubule is about reabsorbing some other solutes, notably calcium. And so this distal convoluted tubule is the second to last portion, and then we move into the collecting duct, which is really just going to add the final touches on to water reabsorption. So when we have defects of this nephron, we see that there are concerns with calcium handling, and so this calcium might not be able to be reabsorbed in the side of the nephron, depending on how much calcium is in the filtrate. And struvite colliculi, and we have urease producing bacteria, right? And so this is going to be the big indicator here. It's associated with a urinary infection, right? So you develop these little crystals, these little stones in your urine from really bacteria, right? And so the pH in the urine at this point will sit at about 7.2. Normally it sits in a little more acidic than that. But we try to buffer our urine as much as possible. Uric acid, again, uric acid is going to be from amino acid decomposition. And so we see that uric acid crystals form when urine pH drops below 5.5. Okay? Now remember, pH is on a opposite scale, so it's logarithmic scale. This pH of 5.5 means it is more acidic. And so we can get insoluble urate formation, which forms uric acid crystals. Okay, so these uric acid crystals can also form in circulation and in joints, and so we see that this can actually be a pretty debilitating disorder to have. Okay. Really an indicator here is rapid or dramatic weight loss, indicating uric acid crystal formation. Okay. And then the last type we have is cysteine. And so cysteine is going to be abnormal secretion or lack of reabsorption of amino acids. And specifically, we're looking for cysteine amino acids. We might look for a couple others like lysine or arginine as well. So how is nephrolithiasis going to manifest itself? And it's generally, you only see manifestations while we're actually obstructing urine flow. Okay. So we might expect hydronephrosis, which we are going to talk about in another audio lecture. Okay? You might experience some pain, UTI. So we did see a case in which we saw bacterial infections, and that was the struvite calculi. Pain is going to be intermittent pain. It's going to come and it's going to go, right? You might expect bloody or cloudy foul odor urine, right? So bloody urine would be damage to the urethral walls and maybe even the bladder. Okay. The cloudy and foul odor urine will be produced from bacteria that could be present in there, especially during the struvite calculi. Okay. Dysuria is going to be pain while urinating. Okay. So if you're urinating out something like this, which would be virtually impossible to have to break this up, it's going to cause a tremendous amount of pain. So something like this would probably even cause some discomfort. We might feel an increased frequency to urinate. There might be genital discharge outside of urination. And then you're going to have general illness manifestations like nausea and vomiting and fever and chills that would accommodate, really associate with an infection. How are we going to diagnose this? Well, first of all, we're going to do a history and physical examination like we always do. Okay. Then you're going to run some urine tests. So you're going to run a urinalysis to look for components in the urine, like white blood cells or bacteria. Okay. You're going to run a culture of the urine to verify the type of bacteria that it actually is. Okay. And you will probably conduct a 24-hour urine collection. So this is when you have a catheter, okay, and it is collecting all urine that you produce in a 24-hour period. And so we might actually expect this urine collection to be less than what it is normal because we have a urinary obstruction, right? There might be a deterrent to going to urinate because of the pain associated with it. Right. We're going to use standard imaging, so looking at our bladder and kidney through an X-ray. CT scan is going to give us a three-dimensional X-ray pretty much. Ultrasound is going to give us a three-dimensional view of it, really real time, and then intravenous pyelogram. Okay, and this is again going to be injecting some contrast dye and then visualizing on an X-ray to be able to see where the issue is. So if there's an obstruction in the urethra, you should be able to identify that through this intravenous pyelogram, but also just a regular X-ray, right? So looking at the urethra, we should be able to see this hard mass sitting in the tube. The best way to diagnose this is obviously looking at the problem itself, and so if you're able to pass one of these calculi and then smash it up and determine what it's made of, and that can give you an idea of what the cause is of it. Okay, and then we might do some serum studies to look at elevations in amino acids, calcium, uric acid, right, or the struvite. So we're going to be looking at the serum to be giving us hints about what the urine is doing because the kidneys and the cardiovascular system are so closely linked. Okay. So for treatment, we're going to really treat the individual types, and so they have specific types, but for more general approaches, we're going to increase water intake to try to urinate more frequently to pass these stones. And then when you pass the stones, you generally pass into a filter of some sort, collecting the stones in the process. Okay. You might disintegrate the caliculi. Okay, so these calculi here we see can be broken up through lithotripsy, and this is going to be really inserting a probe through the abdominal wall or the posterior wall, so it's going through the back probably, okay, and then releasing some ultrasound waves to break up the actual stone so you can pass it easier. We might use percutaneous nephrolithotomy, and percutaneous nephrolithotomy is going to be working through the skin, and so you're not actually going in for an invasive procedure, but you're releasing high frequency sound waves rupture, to break up the stone. So here's the stones over here. The sound waves hit it, or shock waves, pressure waves. And then over here we have the fragmented stone. Now these are still going to probably be pretty painful to pass, but you will be able to pass these small stones. Okay. And then the uteroscopy. So they're using imaging here to actually navigate up through the urinary system. Okay. And this is allowing you to break up the pieces and then extract them if necessary via a clamp or something like that. Okay. So some additional treatments can include antibiotics if we have a bacterial infection, anti-gout agents, and I googled this, and anti-gout agents, this is about as specific as I want to be. There's a number of medications that you could take. We might need to alter your urine pH, right? And so a lot of these crystals will form when urine pH drops below a certain level. So we see that we can get pH dropping 7.2 to 5.5, and that increases the formation of the crystals, because now the crystals, so the salts that end up make up the crystal, are less soluble in a lower pH solution, right? So if we drink water, this might, so it can increase pH over time with the addition of a bunch of water. Prevention is really the best treatments in all cases. So we want to prevent these disorders from running out of control before they really get started. Okay. So for calcium, or for the calcium crystals, we're going to try to treat it by reducing renal reabsorption, or actually this is kind of counterintuitive, because thiazide diuretics actually increase calcium reabsorption. And so what they're doing is they're reducing the amount of calcium that is in the filtrate by reabsorbing a little bit more of it. So thiazide diuretics are not actually direct calcium movers, and so they are a symporter that helps sodium and chloride get into the blood, or so they inhibit the sodium chloride, and so this maintains a low concentration of sodium inside of the cell. And so we really have the strong inward force that sodium wants to move inside of the cell, and in exchange for that, we move the calcium back out. So it's a way to increase absorption of calcium. So thiazide diuretics kind of work a little bit differently. Phosphate, cellulose phosphate, would bind up additional calcium. And then we'll want to decrease parathyroid hormone secretion, right? So parathyroid hormone is responsible for increasing blood calcium, and in order to reduce blood calcium, right, so reduce the amount that is actually filtered, okay, we want to reduce this parathyroid hormone. Okay. So on to struvite. We really want to prevent the UTI from initially getting going. So remember that the struvite is produced from urase producing bacteria, right? And so we want to prevent this bacterial infection as much as possible, and that is probably going to include hygiene, proper hydration, making sure you're not holding urine for a prolonged amount of time, and when you do go, make sure that you're taking care of business and cleaning it up properly. Okay. We see that you might use to treat it percutaneous nephrolithotomy, right? So now here you're breaking up the fragments, and actually I found this image up on the internet as well, and that's that the fragments are actually sucked out. So they are you don't have to pass them through your urinary system, but rather they can remove them through aspiration. So they break them up, and then they can also suck them up as well. Into uric acid. This we really want to dissolve the calculi. Okay. And so we might increase urine pH, and so we need urine pH to definitely be above 5.5, closer to 6.5, and its normal range is where we're really going to want it. And so we can see that potassium citrate also helps dissolve these crystals that are forming. And so you might actually need to modify your diet a little bit to reduce your intake of purines. All right, and the last type of treatment is for cysteine. Okay, cysteine calculi. And the cysteine is going to really be a preventative thing. So we might alter dietary intake of cysteine or lysine or arginine amino acids and try to avoid foods that are high in those. Increase our fluid intake and increase urine pH to above 7.5. And this is about the best we can do for this one. Okay. All right. So this is the audio lecture over urinary tract infections, specifically talking about pyelonephritis.